The standard medullary nailing of the femur with the Simplified universal nail or Syn nail and the Syn Ream set is shown. A hypertrophic pseudarthrosis of the femur is used as the model. For the operation, the patient can be placed in the supine or the lateral decubitus position. In this exercise, the femur is clamped in the vise so that its position corresponds to the supine position used in practice. The medullary canal is opened using the 4 mm centering pin, the universal chuck with T-handle, the cannulated cutter, and the protection sleeve. The point of entry is directly located in the posterolateral region of the piriform fossa, exactly in the prolongation of the medullary canal in the anteroposterior and lateral aspect. To make it easier to find the correct point of entry, the piriform fossa can be divided into thirds in the ventrodorsal direction. The correct point of entry is in the region from the middle third to the dorsal third. Incorrect points of entry can lead to a lateral fracture of the neck of the femur, splitting of the greater trochanter, or to destruction of the blood vessels supplying the head of the femur, dorsal to the neck of the femur. After the centering pin is placed at the correct point of entry of the nail, it is inserted into the medullary canal by turning movements of the universal chuck. The positioning of the centering pin in the center of the medullary canal must be checked in both planes with the image intensifier. The centering pin often has to be repositioned in one or the other of the two planes. If the centering pin has been incorrectly positioned, it's left in place to help orientate the second pin. After the centering pin has been positioned correctly, the universal chuck is removed and the cannulated cutter with the protection sleeve is mounted over the centering pin. In this case, the sleeve is withdrawn to allow a clear view. The medullary canal is opened by pushing and simultaneously rotating the cannulated cutter a minimum of 180 degrees. After removal of the cannulated cutter and the centering pin, the 2.5 mm reaming rod, which has an olive at one end, is inserted. The reaming rod is carefully pushed into the medullary canal with the holding forceps or the T-handle. On this bone model, as is often the case with a hypertrophic pseudarthrosis in practice, penetration of the fracture zone is not possible because of the sclerosed medullary canal. The reaming rod is removed. The sclerosed medullary canal must first be opened with the hand reamers. In practice, hand reamers with diameters of 6 to 8 mm are available. After the medullary canal has been opened, the reaming rod is again pushed into the canal. In the clinic, the correct position of the reaming rod in the distal portion of the femur is checked in two planes with the image intensifier. The reaming rod must come to rest centrally above the notch. In order to prevent a varus deformity or a valgus deformity, care should be taken that the guide wire in the lateral view is also placed in the center of the canal to avoid perforation of the anterior cortex. The reaming instruments consist of a flexible shaft and a set of reamer heads. The reamer heads have diameters of 8.5 to 15 millimeters. Only reamers with sharp, undamaged cutting edges should be used. Blunt reamers generate higher cortical temperatures and increase intramedullary pressure. As an 11 mm diameter nail is to be used in this exercise, we will ream up to 12 mm. For the first reaming, the 8.5 mm reamer head must be used. The shaft can easily be connected to the reamer head by a click-on mechanism. The compact air drive with the attachment for medullary reaming is now employed. By pulling back the ring on the quick coupling, the attachment is opened. The flexible shaft can now be inserted. The universal drill with the angular drive unit could also be used for the reaming procedure. The flexible shaft is guided over the reaming rod. The reamer is pushed into the opening of the medullary canal without rotation. In practice, the soft tissues are protected during the reaming with the tissue protector. During the reaming process, the reaming rod is held precisely in the axis of the femoral shaft by the assistant, using the holding forceps. This prevents the rod from rotating and the reamer from jamming. The reamer is pushed in the distal direction, using the highest drive speed with slight and even pressure, moving the drive back and forth. This frees it from bone material and prevents the reamer from jamming against the reaming rod. After the entire length of the medullary canal has been reamed out, the reamer is withdrawn without bending the reaming rod until the reamer head is completely visible. The reaming rod must be held in position by the assistant to prevent it being pulled out. Should the reamer become jammed during the reaming, it must be removed manually. To do this, the drive must be disconnected. The holding forceps is mounted on the reaming rod. With small blows of the hammer against the forceps, the jammed reamer can be withdrawn from the medullary canal by means of the olive on the reaming rod. Before continuing, the reaming rod is reinserted and its position verified. Alternatively, the jammed reamer can be removed by mounting the T-handle with quick coupling, turning the flexible shaft anti-clockwise, and pulling it back. In the clinic, the reamer head is removed by placing it in the slot of the removing tool for reamers and pulling back the flexible shaft. The reamer and shaft are guided into the medullary canal over the reaming rod. Reaming is now continued in 0.5 millimeter steps until a diameter of 12 millimeters is reached. That is 1 millimeter larger than the nail diameter to be used. The required length of the nail is now determined. A second reaming rod is placed parallel to the inserted rod and the exposed end marked on the second reaming rod with the holding forceps. As both rods are the same length, the protruding part of the second rod corresponds to the length of the rod lying in the medullary cavity, and thus gives us the length of the nail. First, the nail is passed by hand as far as possible over the guide rod into the medullary cavity. The conical bolt is screwed into the proximal end of the nail. The insertion handle is mounted. The tongues of the insertion handle must be well anchored in the grooves of the nail. Care must be taken that the curvature of the nail matches the curvature of the femur. The conical bolt is then tightened with the socket or combination wrench. The locking nut is mounted and tightened with the pin wrench. The cannulated hammer guide is slid over the reaming rod, screwed onto the conical bolt, and tightened. The ram is slid over the guide, and the flexible handle screwed onto the guide. The sun nail is driven into the medullary canal with measured blows of the ram until the proximal end of the nail comes to rest level with the piriform fossa. Care must be taken to ensure the reaming rod does not back out. If the nail does not penetrate farther with each blow, the nail should be removed and the medullary canal reamed another 0.5 to 1 millimeter. When the sun nail is positioned properly, the ram, the cannulated hammer guide, and the reaming rod are removed. The insertion handle remains for the insertion of the locking bolts. Although in practice, indications for proximal locking are dependent on the location of the pseudarthrosis, proximal locking is carried out for the purpose of this exercise. Dynamic and static locking are possible. If the insertion handle is not correctly mounted, the proximal locking holes in the nail may be missed. Before drilling, the locking nut and the conical bolt should once again be tightened. Image intensification is not necessary. The protection sleeve and the trocar are inserted through the static hole as far as the bone. Following removal of the trocar, the drill sleeve is inserted. Both cortices are drilled with the 4 mm drill bit. After the drill sleeve has been removed, the length of the drill hole is measured. The hook must catch in the far cortex and not on the nail. Because the tip of the bolt should protrude beyond the far cortex to ensure sufficient purchase, the locking bolt must be 2 to 4 millimeters longer than the measured length. The locking bolt is inserted. For additional fixation, a second locking bolt can be inserted through the dynamic slot in the nail. Distal locking could now be carried out, although it's not done in this exercise. The insertion handle is removed by first loosening the locking nut one turn and then detaching the conical bolt with a combination or socket wrench. At the end of the exercise, the sun nail is removed. The most proximal locking bolt is removed. The second locking bolt remains in position to prevent rotation of the nail in the medullary canal when the extraction instruments are screwed in. The appropriate conical bolt is inserted into the proximal end of the nail and firmly tightened with the combination or socket wrench. The guide is attached and tightened. The ram is slid over the guide, and the flexible grip is screwed onto the end of the guide. The second proximal locking bolt is now removed. The nail is removed with measured blows of the ram. It's advisable to retighten the conical bolt after the first blow.